Now, moving on to this very interesting topic, that is muscles of the hand. Uh, People usually find this topic bit difficult because there are so many muscles in hand. We have like 20 muscles present in hand, divided in four groups: the thenar, hypothenar, lumbricals, interossei, and having like all these small bones are giving attachment to them. So students at time they find difficult to remember the attachment of these muscles. But once again, if you follow certain rules, if you just apply some logics, it's very easy to remember the attachment of these muscles, action of these muscles, and even to identify these muscles in the cadaveric images. So let us talk about the muscles in hand. As we said, we have around 20 muscles in total, and these 20 muscles are divided in four groups. So these 20 muscles are divided in four groups. Like we have a group of thenar muscles, which are four in number. Then we got hypothenar muscles, again four in number. We got these worm-like muscle called as lumbricals, four again. And finally, we have a group that is called as a group of interossei. Interossei, between the bone, interossei. They're between metacarpals, so we call them interossei. And there are 8 interossei we have: 4 palmar interossei, 4 dorsal interossei. So that takes the total to 20 muscles. Now we've got to take all these groups one by one and let us understand their attachment here. But before going to the attachment of these muscles, there is so much lying in the name of these muscles itself. Now, first we need to understand that why we are naming these muscles in a particular way, and then does that name provide any sort of hint regarding the attachment of that muscle? So this is going to be interesting. Let's start with the first group here, guys, that is the thenar muscles. So we said we have 4 thenar muscles. Now let me name these 4 thenar muscle and then I'll try to justify the name. Like one of the thenar muscle here is called as the abductor pollicis brevis. We call it abductor pollicis brevis. Then we got a muscle called as the flexor pollicis brevis. Third muscle here is opponens pollicis. That is opponens pollicis. And then finally we have the fourth one, that is adductor pollicis. That is the adductor pollicis. So we got an abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and adductor pollicis. Now I want you guys to pay attention to this part, guys. See, when you say when you use the word like longus or brevis in front of the muscle, that is obviously telling about the length of the muscle. We all know that brevis means short and longus is long. Now, obviously, being a thenar group muscle, you can never have a name longus in front of them. None of these thenar muscle or hypothenar muscle or any muscle in hand, for that matter, will have longus in its name, because long muscles will be coming from the forearm. The longest muscle either will come from the front of forearm or from back of the forearm. So you cannot have a longest muscle here. So the muscle that are present in the hand itself, in the thenar or hypothenar region, they are short muscles. So we got to use the word brevis in front of them. But the reason we have used the word brevis here and here in the flexor region and not in these two muscles, because we already have a muscle called as abductor pollicis longus coming from the back of forearm, and we have a muscle called as a flexor pollicis longus coming from the front of forearm. If you already have a longus muscle coming from the forearm region into the hand, that is the reason why we have to use the word brevis to name them separately. But there is no need of any longus or brevis term in front of these opponents and adductor, because there is no other muscle. We only have one muscle for the opposition, simply called as opponens pollicis. No longus, no brevis, nothing. That's the only muscle. And the same case is with the adductor. Adductor pollicis is the only muscle here we have in this group, and there is no other muscle called as adductor pollicis coming from somewhere else. So the reason for using the word brevis over there is because we have a other muscle which is longest muscle coming from the forearm. And this information will go a long way. You'll understand that how this will help you remember their attachments also. Now, guys, out of these 4 muscles, the first 3 muscles which I'm highlighting here, they're all supplied by the median nerve. They're all supplied by the median nerve. There is a recurrent branch of median nerve in the hand, and that supplies these muscles here. Whereas the adductor pollicis is the only muscle in there which is supplied by the ulnar nerve. Is supplied by the ulnar nerve. Yes, flexor pollicis brevis. There are two heads of flexor pollicis brevis, and one of the head can be supplied by the ulnar nerve also, but that is like kind of variation only. Let's stick to the major part. That in usual circumstances, the three muscles that out of these four are supplied by median nerve, and one is by ulnar nerve. Now let us try to utilize this information and try to fetch answer to some wonderful questions in here. Now guys, when I say opponent's pollicis muscle, there is no longus, no brevis, that means for the opposition movement of the thumb, this is the major muscle we have, opponent's pollicis. And that is supplied by what nerve? That is by the median nerve. So if I say a patient comes to you with a carpal tunnel syndrome, we all know carpal tunnel syndrome, the median nerve is involved. So if the median nerve is involved at the wrist region here, so we expect that the thenar muscles are also going to get wasted. Now thenar muscles are being paralyzed or will get wasted later on. But out of all these three thenar muscle, the abductor pollicis and flexor pollicis, these are the brevis muscle which are involved. Longus muscle will still be working because longus muscle is coming from the forearm, that is supplied in here, or abductor is supplied here in this region. They are supplied by the anterior interosseous nerve and posterior interosseous nerve respectively. So that means if the injury is to the median nerve at this point, at the level of the wrist joint, in the carpal tunnel, or you can say, that means out of these three muscles, all the three muscles are involved, fine. But we still have something for the abduction and something for the flexion, which is still working because those muscles are coming from the forearm. That means longus muscle will be working. Only brevis is gone. But opponent's pollicis, when I say opponent's pollicis is a unique muscle, there is no longus, no brevis. We have no opponent's muscle coming from the forearm. And that is why the involvement of opponent's pollicis muscle is the one which we need to keep an eye on. If the question is asked to you that which movement of the thumb is completely lost or something in the carpal tunnel syndrome. Now, okay, all these muscles of thumb are involved in the carpal tunnel syndrome, all these three muscles mainly. Okay. But out of these three muscles, two muscles are having longus still working. But for this muscle, there is no longus. That is the only muscle. So the one movement which is badly affected in the carpal tunnel syndrome for the thumb is what? Is the opposition movement. Opposition movement will be affected here, and that's why we have an ape thumb deformity. We will come to that. So that's one important information we could fetch out by just looking at the name of the muscle and understanding their nerve supply. Okay, let me try to change this question. If I say a patient comes to us with an injury to ulnar nerve, let's say there is a medial epicondylar fracture or anything, I mean any case in which the ulnar nerve is involved. If ulnar nerve is involved, obviously out of the thenar muscle, if I talk about, the thenar muscle which is involved is which one? Adductor pollicis. And once again, adductor pollicis is the muscle with no longus, no brevis, so that is the main muscle for the adduction of thumb. So again, if the question is asked that patient is having an ulnar nerve injury, then which thumb movement is affected or badly affected or completely lost, then obviously you have to go with what? Adduction. So in median nerve injury, at carpal tunnel, opponent's movement is completely gone. In ulnar nerve injury, doesn't matter wherever it is. In ulnar nerve injury, which movement of thumb is gone? Adduction is gone. And needless to say, if there is a radial nerve injury, let's say there is a spiral groove fracture, shaft of the humerus fracture or something, if the radial nerve is gone, obviously all the extensor muscle will be involved. For the thumb, we have two extensors. We saw that in the boundaries of anatomical snuff box also. We have an extensor pollicis longus and extensor pollicis brevis. And both the extensor pollicis muscle are supplied by the posterior interosseous nerve, which is branch of radial nerve only. So that means in case of radial nerve injury, one movement of thumb which is completely gone is what? Extension. Now let me just recapitulate the entire thing. So what we said, in median nerve injury, what is gone? Opposition power of the thumb is gone completely. In ulnar nerve injury, adduction power of the thumb or adduction movement of the thumb is gone. And in case of radial nerve injury, the movement that is affected for the thumb is the extension. The extension of the thumb is affected here. So there is another question which can be formulated out of it. In fact, it was a question asked that movement of which finger can be used to test all the long nerves of the upper limb. If you have to test the median nerve, ulnar nerve and radial nerve, all three of them, then movement of which digit is needed for that? And that is thumb. Because if you're able to do the opposition movement, that means your median nerve is working. If you can do the adduction of the thumb, that means your ulnar nerve is working. And if you're able to do the extension of the thumb, that means your radial nerve is also working. So thumb is the only digit by which you can test all three long nerves of the upper limb. Such an interesting information, and that all can be fetched just by knowing the name of these muscles and try to understand that what their nerve supply is. Let me write all these facts before we go any further. So as we said, movement of thumb completely lost in. Now, what are the circumstances we said? Completely lost in median nerve injury. And when I say median nerve injury, I have to say at wrist or at carpal tunnel. I'll tell you why, because if the injury is higher, there is a different scenario. I'll come to that. Median nerve injury at the wrist, then what movement is completely gone? That is opposition of thumb is gone. Opposition of thumb is completely gone. That was one. Second case, movement of thumb completely lost in the radial nerve injury, the higher radial nerve injury, of course, and in that case, it will be the extension of the thumb. Extension of thumb. And if it is about the ulnar nerve injury, then the movement which was completely lost was the adduction. Adductor pollicis is applied by the ulnar nerve, D branch of ulnar nerve. So adduction of the thumb will be gone. Opposition of thumb, extension of thumb, and adduction of thumb. Right. Let's try to fetch more information in there. Okay. What is the way that extension of, we said radial nerve injury lead to the extension of thumb? We talked about the extension, we talked about the opposition, we talked about the adduction. What about the flexion movement? And what about the abduction movement? Now that is something we haven't talked about here. What is the possible scenario when the abduction of thumb is completely lost and the flexion of thumb is also like completely lost in this case? Okay. Now, if let us say there is a median nerve injury very high, somewhere here. If there is a median nerve injury in the very high, like let's say in the supracondylar fracture, let's say it is above the elbow here. If the median nerve is injured so high, that means the flexors coming from the forearm are involved, and even the thenar muscles are also involved, right? In that case, what will happen? The flexor pollicis longus muscle, which is coming from here, will be involved, and flexor pollicis brevis, which is coming from here, will also be involved. So both longus and brevis will be gone. So if the question says that what is the possible site for median nerve injury in which there is a complete loss of flexion of thumb, and that would be a high median nerve injury, like somewhere above the elbow only, because your anterior interosseous nerve is also supposed to be involved. All these things have to be discussed here only. We should not wait for the nerves to come and then we'll talk about them, because this is going to make a lot of sense right now as you know the name of you are understanding the name of muscles and their action here. See guys, what I'm saying is the median nerve, when it comes down, if let's say this is a median nerve, it gives off a branch, and that branch of median nerve is called as anterior interosseous nerve. I hope you all know that anterior interosseous nerve is the branch of median nerve only to supply the deeper muscles of the front of forearm. Now median nerve as such by itself was supplying the muscle flexor pollicis brevis. I'm just taking the relevant things only. Median nerve was supplying flexor pollicis brevis, whereas anterior interosseous nerve supplies flexor pollicis longus. It supplies flexor pollicis longus. So if there was an injury somewhere here at the level of let's say carpal tunnel or flexor retinaculum, somewhere here, let us say, then obviously only flexor pollicis brevis will be gone. But if the injury to the median nerve is somewhere in this part, higher median nerve injury, like somewhere above the elbow, then your flexor pollicis brevis as well as flexor pollicis longus both are gone. And in that case, there is no flexion of the thumb at all. So if I write it here only, that complete loss of flexion of thumb is due to high median nerve injury. Is due to high median nerve injury. Make sense? Okay. Now let me tell you one of the question which was asked in sometime back in the AIMS exam, and that's again a question which can be understood from here. The question asked was in such a way that a patient comes to you, and when you ask the patient to flex the thumb, now what he's able to do, the patient is able to flex the thumb like this. Now just look at me very carefully, guys. So I'm able to flex the thumb like this, but I'm not able to flex the interphalangeal joint of thumb. I'm not able to flex this joint of the thumb like this. I can't do this. So this is not happening, but the entire thumb can be flexed. Now what does it mean? It means that the flexion at the metacarpophalangeal joint is happening. The flexion at the MCP joint, metacarpophalangeal joint is happening, okay, but the flexion at the interphalangeal joint is not happening. Now how is it possible? Well, it is possible because when the muscle flexor, we talk about the longus muscle, guys. Flexor pollicis longus muscle come from forearm, and this flexor pollicis muscle longus will go till the distal phalanx, till here. Whereas a flexor pollicis brevis muscle will only go till the proximal phalanx. It's a brevis muscle, it's a short muscle, so it will go only till the proximal phalanx. And flexor pollicis longus will go till the distal phalanx. So if your brevis muscle is working, listen to this. If your brevis muscle is working, but longus is not working, then you can flex a thumb like this at metacarpophalangeal joint. But because your flexor pollicis longus is not working, so you cannot flex the interphalangeal joint. So how is it possible? Well, it is possible, we said, if your FPB is working, this one is working, and FPL is not working. And that is possible in what nerve injury? In the anterior interosseous nerve injury. If it's not a main median nerve injury, if only the anterior interosseous branch of median nerve is involved, then a patient will be able to flex the thumb at metacarpophalangeal joint, but will not be able to flex the thumb at interphalangeal joint here. Let me write that also. That anterior interosseous nerve injury. In case of anterior interosseous nerve injury or involvement, what will happen? Flexion at metacarpophalangeal joint is intact, but flexion at IP, interphalangeal joint of thumb, is lost. Flexion at the metacarp, obviously first metacarpophalangeal joint we are talking about. Flexion at MCP joint is intact, it is there, but flexion at the interphalangeal joint of the thumb will be lost. So I hope you understood this concept in there, because when you get questions like these, the options will be a bit confusing here. They will say a patient is able to flex the thumb at MCP joint but not at interphalangeal joint. Which nerve is involved? And there are very good possibility that you will find median nerve in the option. Now obviously you cannot go with the median nerve as such, because when I say median nerve injury, then it means everything is gone, right? You have to go with a more precise answer, and the precise answer is a branch of median nerve. And which branch is that? That is anterior interosseous nerve we are talking about. So coming back to the original topic, we are talking about the muscles in here, guys. So we talked about the 4 muscles in the thenar region, and let me write the name of 4 muscles in hypothenar region. Now coming to the second group, and then we'll talk about them, their attachment also. Hypothenar. So we got 4 hypothenars also, and the names of these hypothenars, they quite correspond to the names of the thenar muscles. Like if you look at the first 3 thenar muscle, it was abductor, it was flexor, it was opponens. Same story here. Here again we will have an abductor. Let me just write those names only. Abductor. Here also you will have a flexor, and you will also have an opponens. But of course, this time we are talking about the hypothenar region, and hypothenar muscles are for the little finger, for the digiti minimi. That's why they will have a word digiti minimi attached to them. So it will be abductor digiti minimi. Abductor digiti minimi. There will be flexor digiti minimi and opponents digiti minimi. Of course, they're all digiti minimi muscle. The fourth muscle here is something that you have to remember. There is one more muscle in the hypothenar region, and that is a subcutaneous muscle here. That muscle is not having any bony attachment. It is just present, it is attached to the medial side of flexor retinaculum and just is present subcutaneously here. It just makes the skin on the ulnar side of hand bit thicker here. So that's the only subcutaneous muscle that you see in the hand, and that muscle is called as the palmaris brevis. The muscle is a palmaris brevis, and as I said, it is a subcutaneous muscle. So we'll not talk much about it. It's a subcutaneous muscle. And all these muscles that we're talking about here, all of them, they're supplied by the ulnar nerve only. They're supplied by the ulnar nerve. Yes, all the muscles in the hand, they're supplied by the deep branch of ulnar nerve, except palmaris brevis. It's a subcutaneous muscle. So it is the only muscle which is supplied by superficial branch of ulnar nerve, which we will talk about in the ulnar nerve itself. So if you remember that all the hypothenars are by ulnar nerve, that is good enough information as of now. Now guys, now we have 4 thenar muscles and we have 4 hypothenar muscles with that. Let's ignore the palmaris brevis because there is no bony attachment, and let's talk about the attachment of the remaining 7 muscles, 4 thenar and these 3 hypothenar, and it's very easy to understand and remember the attachments. So let's go. Now I'm going to draw this diagram schematically for you. Let's say here we have the 4 carpal bones in the proximal row and 4 carpal bones in the distal row. No fancy diagrams, nothing, just let's go with a simple one. This is scaphoid, lunate, triquetral, pisiform. We got the trapezium, trapezoid, capitate and hamate. Trapezium, trapezoid. People usually confuse which one is trapezium and trapezoid, so make sure it's trapezium and then trapezoid. So obviously from the lateral to the medial side we are going, the 4 carpals in the proximal and the 4 carpals in the distal row. Then we go further in here, so obviously there will be attachment of metacarpal. There we have it. This is the first metacarpal. The second, third, fourth, and let's say this is the 5th metacarpal. And finally phalanges. As we know that we have like 14 phalanges, 3 for each digit except thumb, which is only having 2. So they are the 2 phalanges for the thumb. Just keep it very simple so that our main purpose is solved here of understanding the attachment of the muscle. Now, one thing that you got to keep in mind is that when you say thenar and hypothenar muscle, obviously the thenar muscles are toward the lateral side and hypothenar are toward the medial side. So there's no rocket science, and you just have to remember that what are the bones toward the lateral side and what are the bones toward the medial side. So if you look at the carpal bones, of course, the scaphoid bone and trapezium bone are the major bone which are carpal bones on the lateral side here. And if you talk about the medial side, it has to be the pisiform and the hamate. So if not for all, but majority of the thenar muscles will come from these 2 bones, and majority of the hypothenar muscles will come to from these bones. Where they will go, we'll come to that. So just let's have a broad idea first. Second thing what we said, guys, that thenar and hypothenar muscles are the short muscles. Of course, they are the short muscles in hand. And you will never ever have any muscle of thenar or hypothenar region going beyond the proximal phalanx. You can have attachment proximal to that, but not distal. The most distal attachment of any of these bones, doesn't matter. None of the thenar muscle is going to go beyond this. Thenar muscle I'm talking about only. And none of the hypothenar muscle is going to go beyond this one here. So proximal phalanx of thumb and proximal phalanx of little finger is going to be the distal most attachment of any of the thenar or hypothenar muscle. Now see, with that, we already got an idea about that where the thenar muscles are going to originate and where they will insert. Not a precise idea, but yes. Now I want you to think about the names of the muscles and then let's try to apply those muscles in there. If you look at the thenar region, the name of the muscle was flexor pollicis brevis, abductor pollicis brevis. Let me take the first two muscles in there. Now, flexor pollicis brevis and abductor pollicis brevis muscle, they take origin from the scaphoid and trapezium. Yes, in textbook of anatomy, they mention it more precisely like tubercle of scaphoid, crest of trapezium, hook of hamate, but we don't have to go into that detail. If you just remember the name of the bone, from where they're originating, that is that more than enough. Nobody is going to go into that kind of detail. And obviously, if you remember, we also said these four bones are providing attachment to the flexor retinaculum. So whatever flexor retinaculum will be present in here, that retinaculum will also is giving attachment to majority of the thenar and hypothenar muscle, most of them. Okay, so look at that. So I'm keeping it in this way. Let's say this here is going to be the common origin for the thenar muscle, most of them, if not all. And this here is going to be the common origin for the hypothenar muscle, right? Now look at how I'm going to draw this muscle. I'm looking at one muscle which is coming to this, and second muscle is also coming to this. Now it looks like more or less that the origin is same, although there is a bit of variation in there. But the insertion of both the muscle is toward the lateral side of the base of proximal phalanx of the thumb. Lateral side of the base of proximal phalanx of the thumb. Then how can these two muscles have a different action? Well, the muscle which is present more outside, and you can apply the same perspective in the cadaveric image also, and still you can identify those muscles. If the muscle is present more outside, this muscle will tend to pull the thumb outward like this. So that muscle is for the abduction. But with the more or less similar attachment, if the muscle is more toward the palmar aspect, more inside comparatively, that muscle will not pull the thumb outside, that will pull the thumb inside. So that will cause the flexion of the thumb. And that's why when you see a muscle like this, which is present more outside here, that muscle has to be the abductor pollicis brevis. You can see it any atlas and you will realize that it is present more outside. And with a more or less similar attachment, but the muscle which is more present inside is the flexor pollicis brevis. Flexor pollicis brevis. What is the third muscle? Third muscle, there was opponens pollicis. Now, this is important, guys. Opponens pollicis muscle. Now, when I say the word opponens, what is the meaning of the opposition of thumb? Opposition of thumb means that we have to flex the thumb and we have to medially rotate the thumb so that it can face other fingers. Now, the point is, now just let's try a little experiment here. This is my first metacarpal. If I hold my first metacarpal tightly, let me just very tightly hold my first metacarpal, I can still do the flexion, no problem. I can do the flexion. You can try it, right? But I cannot do opposition. I cannot take my finger against other fingers. Why? Because I'm holding my first metacarpal. The moment I release my first metacarpal, now I can rotate the thumb and can take it against other fingers here. Which tells me that for the opposition of thumb to take place, the movement of metacarpal is very important. That is why opponens pollicis muscle may have the same origin. Origin might be same, but insertion cannot be on the phalanges because we cannot rotate the phalanges. What is to be rotated? Metacarpal is to be rotated here. And that's why the opponens pollicis muscle attachment will be on the shaft of the metacarpal. It will be on the shaft of the metacarpal. So this is an important thing to understand, guys. I'm saying the opponens pollicis muscle is attached to the lateral side of shaft of first metacarpal. I'm not saying base because on the base of the first metacarpal we have a muscle that is abductor pollicis longus coming from here. That is abductor, different muscle. I'm not saying on the medial side of the shaft of first metacarpal because that is a site for the first palmar interossei. So when you talk about the muscles, especially for the thumb part, you have to be very, very careful about that where exactly they're attached, because recently there was a question on this also. There was if you need to check out where the pointer is. Is it on the shaft of metacarpal? Is it toward the base of metacarpal on the lateral side, or is it toward the medial side? Right now I'm talking about on the shaft on the lateral side, and that is where what muscle is attached? Opponens pollicis. This is the attachment of the opponens pollicis. Coming to the other side here. Now, there is one more thenar muscle left. Let me just keep it for now. I'll come back to this. If you have the three thenar muscles like this, the three hypothenar muscles were also having more or less the same name only. Abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. I think I don't have to do anything in there. I just have to draw 3 lines like 1, 2, and 3, and you can easily identify which muscle am I talking about. If a muscle is present more on the outer aspect here, look at this, guys. This muscle is what? That is abductor digiti minimi. Same attachment more or less. The muscle is more inside here. That is flexor digiti minimi. Further in, this muscle here is the opponent's digiti minimi. That's what I'm saying. If you try to apply the logics, you don't have to remember unnecessary all these attachment here. Try to remember it diagrammatically, and there's so much logic to it here. You just have to find out the lateral most bone. You have to choose the proximal phalanx. You got to go more laterally for the abductor, more inside for the flexor, and for the opponents, you have to go to the metacarpal. Exactly same mirror image on this side, and that is the attachment of hypothenar muscle. Was it that hard? But one muscle coming to that one was adductor pollicis. I'm going to show you the picture of that muscle as well. Adductor pollicis. Now that's a different muscle altogether. Why? Because all these muscles are clubbed together here and they are forming this thenar eminence. And all these muscles are clubbed here on this side and they are forming the hypothenar eminence. Fine. But adductor pollicis muscle has to work opposite to abductor. This is abductor. So adductor pollicis muscle will be coming on this side here, coming from this side here. And because adductor pollicis muscle has to work against all these muscles which are more toward the lateral side, so the muscle has to be very, very strong. How a muscle can be strong? How can you have a strong muscle in the small region like hand? Well, you cannot afford to have a huge muscle like biceps or triceps in the hand, of course. So either you will have a muscle which is having a longer attachment, I mean the muscle length is more, and secondly, the muscle is having two heads. That will make it even more stronger and the torque force will increase. So what you will see, the adductor pollicis muscle is coming from the shaft of third metacarpal. Guys, this is one thing which people usually mistake about. I'm not saying second metacarpal, I'm saying third metacarpal. Look at this. The transverse head of adductor pollicis will come from here. And oblique head of adductor pollicis will come from the base of second metacarpal, third metacarpal, as well as capitate bone. Look at that. I'm going to draw this for you, just telling you first where it is coming from. So this head will go like this and attach to the medial side of same proximal phalanx only, no change in that. That is a transverse head of adductor pollicis coming from where? From the shaft of third metacarpal. And the oblique head is coming from this capitate bone, from the base of second and third metacarpal, and again going to the same base of medial side of proximal phalanx. I'm writing this is the transverse head, I'm writing TH here, and this is OH, that is oblique head. Transverse head and oblique head, what muscle? Of the adductor pollicis. Of the adductor pollicis. It's a very, very important muscle to be remembered. Anyways, hand muscles are extremely, extremely important. Looking at the current scenario, they love asking questions from the muscles of hand. So you got to be very thorough with their attachment and their nerve supply, and also about their attachment, as I said. Adductor pollicis having a transverse head and the oblique head. And because of this transverse and oblique head, there is a gap also in between. And yes, this is the gap which is allowing the radial artery to come inside and then continue here to form what arch? The deep palmar arch. Something we already discussed, that deep palmar arch will be the continuation from there. Let me show you this muscle. Let me show you the adductor pollicis muscle in one of the picture that I've got for you. Look at the guys. Look at this beautiful muscle in there. That is adductor pollicis. Look at the transverse head is not coming from the second. It is coming from the shaft of third metacarpal and going toward the proximal phalanx, right? That is the oblique head will be coming from the base of this second metacarpal, base of the third metacarpal, and you can see from this capitate also. So all three are providing origin to oblique head, and that is coming in there. And that gap in between, look at this radial artery going backward into the anatomical snuff box. So it will go back into the anatomical snuff box. It comes between the first dorsal interossei. I told you, it comes out between the first dorsal interossei, and then now comes between the two heads of adductor pollicis and forms what arch here? That is a deep palmar arch. So I hope you got an idea about the thenar and the hypothenar attachment. Hypothenar mein one muscle was palmaris brevis. We are not talking about it because palmaris brevis muscle anyways is a subcutaneous muscle. Now coming to the third group, I'll show you the picture for that also, but let me just discuss it. The third group is the lumbricals. The lumbricals. We got four lumbricals, as we said. We got four lumbricals, and let me tell you in the beginning only, guys, the lateral two lumbricals. If we divide them in lateral two and medial two, the lateral two lumbricals are unipinnate. The lateral two lumbricals are unipinnate, and medial two lumbricals are bipinnate. This pinnation not only will help you remember or identify these muscles, will also help you remember the nerve supply also in a way. I'll tell you that. Lateral two unipinnate and medial two are bipinnate here. Lateral two unipinnate lumbricals are supplied by the median nerve. It's the median nerve supplying the lateral two, whereas the medial two bipinnate lumbricals are supplied by the ulnar nerve. Now this information will go a long way, we will see that. So two lumbricals by median nerve and two lumbricals by ulnar nerve. Remember, the lateral two, the first and second are by median nerve, third and fourth are by the ulnar nerve. Please understand that when you talk about lumbricals, guys, lumbricals, whether they are present in hand or they are present in foot, lumbricals muscle are the one which take origin from the tendon and they insert on the tendon. So these are like tendon to tendon muscle. And the name is such like lumbricals. Lumbrical means worm-like. They run like a worm. They start from the palmar aspect, but they will end on the dorsal aspect. And how it is done, I'll show you in the picture also. So the muscle will actually start from here and then will turn backward from the web space and will go backward and insert on the extensor tendon. And that's how they have a different action on the different joint. Now first, let me go with the same as I said. Ki lumbricals, they do have attachment coming from the tendon. So let's say if I just roughly draw this hand for you, this here is a thumb. So guys, a muscle that we need to talk about here is the muscle that is flexor digitorum profundus. So let's say with the muscle here is a flexor digitorum profundus. Four tendons are there and these four tendons are going to the distal phalanx. That is tendon to index finger. That is the tendon to the middle finger. This tendon goes to the ring and this is to the little. So what you're looking at as of now here are the four tendons. These are the four tendons of which muscle? Flexor digitorum profundus, the deeper muscle. Flexor digitorum profundus tendons. And this is going to be the origin for the lumbrical muscles. Let's see how. Okay. So what's going to happen here? We said first two lumbricals are unipinnate. The unipinnate, so what you'll see that these muscles take origin only from one side of the tendon. Like first lumbrical will take origin only from this side of this tendon here. And will pass from this first web space to go at the back. Where they're going at the back, I'll tell you. That's the first lumbrical. Second lumbrical is also unipinnate, that is also arising from the lateral side of this tendon and will go from the second web space at the back of the middle finger only. But third and fourth lumbrical, we said these are bipinnate. So they will take origin from both the side, from the contiguous side. Here as well as here. So that's a third lumbrical, which is a bipinnate lumbrical taking origin from both the side and then going from the third web space behind this digit. And same is with the fourth lumbrical, that also is a bipinnate lumbrical taking origin from both the side of this tendon and going behind the little finger. If I just give them L1, L2, L3 and L4. If you remember, L1 and L2 supplied by the median nerve, the lumbric, the unipinnate one. L3, L4, the bipinnate lumbrical were supplied by the ulnar nerve. Where are they going at the back and what exactly they're going to do? For that, let me show you a picture before we write it down, guys. Lumbrical muscle, as you just saw, that originated and they turn backward. Now, where they're going when they turn backward? Here we go. Now, first, look at this picture here in which you can see the lumbrical muscle. Although this image is like a mirror of what we just drew. We drew the thumb on that side and the thumb is here. So you can see, look at this. That's a tendon of flexor digitorum profundus. Let me enlarge it even further for you. You can see the tendons of flexor digitorum profundus. Look at first and second lumbricals, these two, because we have to start from this side here. First lumbrical, second lumbrical unipinnate, going at the back from the second web space. Third lumbrical, fourth lumbrical, they are bipinnate, coming from both the side of tendon, and they are also going back to the respective digits here. But where are they going at the back of the respective digit? That can be understood by looking at this picture. Now it's a picture of the side of the finger, guys. Look at this. Here's the lumbrical muscle. I want you to focus on one image here. Here's the lumbrical muscle. What you see, lumbrical muscle is going like this from the web space. So when you see the metacarpophalangeal joint, the lumbrical muscle is anterior to the axis of the joint here. The lumbrical muscle tendon is passing anterior to the axis of this joint here. But then this lumbrical muscle will go back and insert into the extensor hood, or you can say into the extensor tendon. And obviously extensor tendon is running on the back of the fingers. That's why the pull of the lumbrical muscle, when this lumbrical muscle contracts, it will produce the flexion at this joint, at the metacarpophalangeal joint, because the muscle is in front. But now the muscle has come behind and inserted here. So the contraction of this muscle, though it causes flexion at MCP joint, it is going to cause the extension at interphalangeal joint. That means something like this. If you make your hand in this manner, that is a function of lumbrical muscle. The flexion at what joint? Metacarpophalangeal joint. And extension at what joint? Extension at the interphalangeal joint is the function of lumbrical muscle. And that is the reason, if imagine lumbrical muscle is gone, if it is not working, if it is paralyzed, what will happen? There will be antagonistic movement. Like the flexion at the metacarpophalangeal joint, this joint will not be flexed any further, it becomes hyperextended. And the extended interphalangeal joint will become what? Flexed. And that you already know can cause what? That can cause a claw hand. That can cause a claw hand. So, see, that's the movement I was talking about. This is what exactly the lumbricals are doing. You can see they're causing the flexion at what joint? Metacarpophalangeal joint, and they're causing the extension at interphalangeal joint. And let me tell you here itself that it is not only done by lumbricals, even interossei. Look at this here. This cut section is for the interossei also. Both palmar interossei and dorsal interossei will also do the same thing. Flexion at MCP and extension at interphalangeal joint. Yes, interossei muscle have some other function also. Interossei muscle can do the abduction and adduction in the fingers. But when you look at a common function, lumbricals, palmar interossei, dorsal interossei, all these muscles have one common function, and that is flexion at metacarpophalangeal and extension at interphalangeal joint. That is going to be common. Let me just write down for you. So we said this is obviously the origin in here. What about the insertion? The insertion of the muscle, I'm writing insertion here. This insertion of the muscle is on the dorsal digital expansion. You can simply say extensor tendon, but more precisely you can say dorsal digital expansion. Action, I'm using for the action here. Action is what? It is causing the flexion at MCP, flexion at metacarpophalangeal joint, and extension at interphalangeal joints. Flexion at MCP joints and extension at interphalangeal joints. That is a function of the lumbricals. Now coming to the last group, that is interossei. So we have talked about the thenar muscles, hypothenar muscles, and now we're done with the lumbricals also. We are talking about the nerve supply simultaneously. Interossei. Now this is the one group of muscle which in the current scenario is one of the most important questions from the upper limb. Like the examiner, they love asking questions from the interossei, the palmar interossei, the dorsal interossei, about their variation in attachment, about which finger is devoid of palmar interossei, which is having dorsal interossei, which finger is having a double interossei. So some questions of that sort. So coming to the fourth and the last group in the muscles of hand, and that is about the interossei. As we said, we got a palmar interossei, we got a palmar interossei, and we got a dorsal interossei. Once again, you should know that palmar interossei, all palmar interossei are unipinnate, and all dorsal interossei are bipinnate. All dorsal interossei are bipinnate. And guys, whether they are unipinnate or bipinnate, one thing that all of them are supplied by deep branch of ulnar nerve only. They're all supplied by the ulnar nerve. So when it comes to the interossei group, whether it is palmar, whether it is dorsal, unipinnate, bipinnate, doesn't matter. Every interossei is supplied by the deep branch of ulnar nerve. Let us understand the attachment of these interossei and the action. So once again, we're going to go with some very schematic diagram in there. Let me just put a divider here. On one side, we'll talk about the palmar, and on one side, the dorsal interossei. So I'm starting with the metacarpal. No need of any phalanges in there. Let's say this here is the 5th, 4th, 3rd, 2nd, and the first metacarpal. Let me draw it slightly more oblique. Phalanges 1, 2, 3, 1, 2, 3. And obviously for the thumb, we got 2. So I'll be reading the same image here also. I can afford to copy paste. Okay. Please take your time, but if you're writing, make sure you draw it first before we go any further. So on this side, we'll talk about the palmar interossei. And here we will talk about the dorsal. Now, I'm sure that you all must have heard of that mnemonic for the palmar and dorsal interossei. The palmar interossei, we use the word pad, and for the dorsal interossei, we say it dab. Palmar interossei is for the adduction, and dorsal interossei is for the abduction. Pad and dab. Add and ab. Palmar interossei helps in adduction, dorsal interossei for the abduction. Because you got to keep in mind their action, and then it will be easy for you to remember their attachment. Now, when I say abduction and adduction in hand, the first thing you need to understand, guys, our principal digit here is going to be the middle finger. So with respect to the middle finger, we talk about the adduction and the abduction of the other fingers like this. So the principal digit here, the axis digit here is this one. That is a middle one. This is a middle one. Now palmar interossei is for the adduction. That means the action of palmar interossei is to bring all the fingers close to the middle in this manner, right? This is what they're supposed to do. An action of dorsal interossei that we got to take other fingers away from the middle finger. That will be the possible action of the dorsal interossei. Fine. Now we said palmar interossei. Let's focus on one at a time, guys. Palmar interossei, we said they are unipinnate. Unipinnate so that they will be taking origin only from one side of the metacarpal, not from both the sides. Palmar interossei, because they have to do adduction. So what you'll see, that first palmar interossei, now look at this, guys. First palmar interossei will take origin from this medial side of the shaft of the first metacarpal and will go at the back. You already know where they're going at the back. They will go at the dorsal digital expansion. Same. Just like lumbricals, they are also going back to the dorsal digital expansion. Second palmar interossei will take origin from the medial side of the shaft of this second metacarpal like this, and the same way it will go behind the second digit, then the dorsal digital expansion. So obviously you can see how the muscles are arranged. When they will contract, they will pull the finger close to the middle finger. What about the third and the fourth? Now third and the fourth palmar interossei are not attached to the third metacarpal. Now they are attached on the lateral side of the third and the lateral side of the fourth and the fifth metacarpal, sorry, not third, and going at the back of those digits. And that's how they will bring the fingers close to the middle here. They will pull the finger, these two fingers toward the middle, and these two will pull the finger toward the middle here. And that tells me one thing here, that the middle finger is the one which is devoid of palmar interossei. That's one question here. That's middle finger which is not having, there is no palmar interossei. There is no palmar interossei on the middle finger. Now, guys, if I say this, let me give them name here. Let us say this is P1, palmar interossei P1, P2, P3 and P4. The 4 palmar interossei here. Now, if I ask you this question that out of P1, P2, P3, P4, which P, which palmar interosseous can be absent? And it's very frequent that like some are having that palmar interosseous, some are not having it. And the answer is the first one. The first palmar interosseous, you can very well afford to not have this palmar interosseous, and doesn't matter. Why? Because the function of palmar interosseous is the adduction of the thumb. And we already have a very strong adductor of the thumb. We just saw the picture of that also, having transverse head, oblique head. What muscle was that? That was adductor pollicis. We do have adductor pollicis muscle, so we may not need this first palmar interosseous. That's why this first palmar interosseous like may or may not be present. It is absent at times. So you can note that point also, that P1, the first palmar interosseous, can be absent. The first palmar interosseous can be absent. So that's the information we need from where? From the palmar interosseous here. And of course, one more thing which you should know, that because palmar interosseous are bringing the finger close to each other, so the test which is done to check the integrity or the power of the palmar interosseous is called as a card test. You just place a card between the fingers, and then you ask the patient to like hold that card between the fingers so that we can check the power of palmar interosseous, and you try to pull out the card. You see that whether you are able to hold that card or not. So the test which is done to check the integrity of palmar interosseous, that test is called as a card test. To check the integrity of palmar interosseous, the card test can be done. What about dorsal interosseous? Dorsal interosseous, first of all, we said all are bipinnate. Now that's the first thing, they are all bipinnate. So that means they are going to take origin from the contiguous side of all the metacarpal. The first dorsal interosseous, this is second dorsal interosseous, this is third dorsal interosseous, and that is a fourth one here. We got to understand the logics behind these guys. So you just cannot mug these up. D3 and D4. So we got a 4 dorsal interosseous. Now you have to think, okay, dorsal interosseous bipinnate, fine. But where exactly they will go? Now again understand the requirement, the need. We have to pull the fingers away from the middle. You don't need an abductor for the thumb or the abductor for little finger. We already have that. We have a muscle called as abductor pollicis longus, abductor pollicis brevis. So there is no muscle needed for the abduction of thumb. We already have enough. So thumb do not need dorsal interosseous. Same story with the little finger. Little finger was having abductor digiti minimi. No need. So even abductor digiti minimi is there. So there is no need for the abduction for the little finger done by any other muscle apart from abductor digiti minimi. So first thing first, that there is no need, and that's why we do not have dorsal interosseous present on the first and the last digit. So then how rest of the digits are going to attach? Now the thing, that's the point. The first dorsal interosseous will go behind the index finger. The last one will go behind the ring finger. And the remaining two, both of them will go behind the middle finger. Both of them. One from the lateral side, one from the medial side. They both go behind the middle finger, which tells me another question here. The digit which is having a double dorsal interosseous is the middle finger. Once again, let me write that point for you. What I'm saying, thumb and little finger, there is no dorsal interosseous. I'm writing DI, no dorsal interosseous. Middle finger is having the double dorsal interosseous. We have 2 dorsal interosseous. Which two? Second and third. The second and third, D2 and D3. Second and third dorsal interosseous, they're both going behind the middle finger. So these are some important things to be understood regarding the attachment and action of the palmar and the dorsal interosseous, that how they are originating, which one are unipinnate, which one are bipinnate, and how exactly they're going and attaching to which digit and which one is devoid of that. They will ask you a clinical question, like a patient comes to you with a crushing injury of the thumb. So let's say a person is working on some machinery and his thumb goes inside that machine and there's a complete loss of the thumb. So if a complete loss of thumb will be there, they might ask you this question, that which muscle is still intact, is still working, or is not affected. Well, that is dorsal interosseous, because there is no dorsal interosseous on the thumb. Similarly, the same goes right for which one? That is for the little finger. If it was a case of palmar interosseous, it is a middle finger. If middle finger is injured or something like that, the muscle which is not affected is a palmar interosseous, because there is no palmar interosseous on the middle finger. So you can always convert these questions into the clinical one. If you have the basic knowledge, you can always fetch the answers. Let me show you the picture too before I conclude here for the palmar and the dorsal interossei. Well, guys, look at this image here. This is showing you the palmar interossei. Once again, look at this. This is the P1 here. This one is P2. This is P3, and this is P4. You're looking at the 4 palmar interossei. The first, second, third, fourth, all of them are unipinnate. And obviously, you can see there is no palmar interossei ultimately going to the middle finger. Dorsal interossei, all of them are bipinnate. If I take you to the dorsal interossei, look at that. That is D1, D2, D3, and D4. Again, ultimately, when you see their insertion, none of them is going to the thumb, none of them is going to the little finger, and 2 are going to the middle finger here, the D2 and D3 here. And again, something to be noted here, it's always good to keep looking at other things as well. Look at the dorsal interossei, guys. What I told you, that between the 2 heads of dorsal interossei, I told you in the blood supply, between the 2 heads of dorsal interossei, we have a space which will give passage to the radial artery. And we said that once this radial artery comes through this dorsal interossei, then it also has to come between what? Between the 2 heads of which muscle? Adductor pollicis muscle, which we saw somewhere here. Look at that. So once it comes between the dorsal interossei, then it comes between the 2 heads of dorsal adductor pollicis, and that's how the deep palmar arch is formed. If you keep looking at the same concept from a different aspect or scenario, then you tend to remember it here. So that is about the muscles of the hand, the attachment of the muscles of the hand. Well, as I said, there is something about the nerve supply, and this is not a rule, but this goes good with the upper limb and lower limb both. In the hand and foot, there is a certain thing, if you try to follow that it is very easy for you to remember the nerve supply of most of the muscles, if not all. Now, let me tell you what exactly am I talking about here. Guys, all adductors plus bipinnates plus interossei. In fact, I should not say plus, I should say or. All adductors or bipinnate or interossei, or like even a combination of the two. If any muscle is following any one of these rules in the hand or even in the foot, let me tell you that. Let me go with the hand first. If a muscle is either adductor, or if it is a bipinnate muscle, or if it is an interossei, if any of these 3 things is fulfilled by the muscle, that is definitely going to be supplied by the dominant nerve of the hand. And what is the dominant nerve of the hand? That is ulnar nerve. So all adductors, bipinnates or interossei, they are going to be supplied by the dominant nerve of hand and foot also. This will work in case of the anatomy of the foot, and you will find this very fruitful, this information. Now let's try to apply this, guys. In the thenar region, see, I'm not saying that ulnar nerve will supply only these muscles. I'm saying these muscles are definitely supplied by the dominant nerve. You can have more muscles supplied by the ulnar nerve or dominant nerve, but this is definitely supplied by the ulnar nerve itself. Like if you look at the thenar muscle, in the thenar group, adductor pollicis only. Adductor pollicis was supplied by what nerve? Ulnar nerve. And that's what we said, all adductors. When we talk about the lumbricals, we have 4 lumbricals, 2 unipinnate and 2 bipinnate. The 2 bipinnate lumbricals were supplied by what nerve? Ulnar nerve. Bipinnates by ulnar nerve. And we just discussed interossei, palmar interossei, dorsal interossei. Doesn't matter if it is a unipinnate or if it is a bipinnate. Doesn't matter. If it is an interossei, it is supplied by what? Ulnar nerve. We saw palmar interossei were unipinnate and dorsal interossei were bipinnate. But because they're interossei, so we are not bothered about whether they are unipinnate or bipinnate. They are supplied by the ulnar nerve. That ways you can easily remember the innervation of the muscles in hand and foot effectively. Right? So this is about the muscles of the hand, and you got to understand this topic very well to answer a lot of clinical questions and also questions directly anatomical questions also in this.